So thank you for coming, you guys. Just to give you a bit of a background on myself in terms of where I came from with this area of research is my background and training has always been in exercise science and first of all exercise physiology and then exercise psychology. So I have dual degrees in psych and in kinesiology. And then, and when I was doing my PhD, I had the opportunity of working with Dr. Don McKenzie, who is the individual who sort of started the movement for dragon boating for breast cancer survivors. And in his capacity, he was interested in the physiology and trying to dispel the myth that women should not exercise after having mastectomy in the event that they might develop lymphedema. So his choice was dragon boating because it was an upper body strength-based activity to sort of dispel this myth. He is a physician as well. So, so in working with him, you know, my interest was in the psychology aspect of it while he was doing the physiology stuff. And so, so that was really the beginning of my interest in breast cancer and in cancer in general. And after moving from Vancouver, which is where I did my PhD, to Montreal, it was more a matter of trying to figure out what the women were getting from in dragon boating that we could develop into other interventions, because not everybody either wants dragon boating or has access to water and the dragon boats that exist. So we want to be able to give them you know, the best possible interventions. So with that in mind, you know, one of you know, sort of maybe along the way I'll give you my pet peeves in this whole area, but of course, you know, this is an area that's, you know, has a ton of research. We know there's a lot of interventions out there. We know bringing people into the gyms, having them exercise is beneficial, and moving on from all that research, what I feel is that we've jumped too fast into the intervention research without fully understanding the context of physical activity and how to get more people active, because across Canadians aren't active enough, cancer survivors aren't active enough, cancer patients aren't active enough. So I think we've kind of jumped too far into doing bring them into a gym 5 days a week for 30 minutes kind of routine, because even though it's beneficial short term, when people leave the gym atmosphere, they don't go back to exercising. So that's really the context of what I'm going to talk to you today about. You know, most of you are probably aware of a lot of these early slides that I put in here, but really just to highlight the fact that once individuals are diagnosed with cancer, they are more susceptible to mental health problems, including depressive symptoms, stress, anxiety. One of my other areas of interest is in body image, as well as the physical health comorbidities, including the ones up there, so fatigue, pain, immune function challenges, biological functioning, which is often studied using cortisol or stress measures, and a variety of health conditions. And so once someone's diagnosed with cancer, and in particular something like I focus on in breast cancer, the survivorship rates are quite high, but the comorbidities associated with having had cancer are also quite high. And so we need to identify these modifiable factors that we can intervene and help these individuals become healthier and reduce their risk for these comorbidities. So of course, my interest is in exercise, and this is one of the areas that I think physical activity is probably one of the strongest known non-pharmacological intervention that we can give to individuals after cancer to help reduce their risk of comorbidities as well as improve their survivorship experience. So for those of you who aren't familiar with the physical activity guidelines, now we do have guidelines. These were first published in 2010, and now there's been a number of other guidelines published around different cancer survivor groups or cancer groups. Generally speaking, the guidelines suggest to avoid inactivity, so promoting physical activity. Individuals should be active as much as they can be, basically. It's feasible, it's safe, it's effective to be physically active. And the guidelines suggest cancer survivors should engage in 150 minutes of moderate to vigorous intensity physical activity per week, plus 2 to 3 days of muscle strengthening activities and flexibility exercises on the days when they do any of the other exercises. So really, for those of you not familiar with general Canadian physical activity guidelines or American guidelines, these are exactly the same. So the guidelines are no different for survivors of cancer as they are for the general adult population. We should be engaging in this level of physical activity. So in a lot of work that we do, we often look at what role physical activity plays in a variety of contexts across what we call the survivorship trajectory, whatever you want to call it, or the continuum, ranging from pre-diagnosis all the way through to end of life. Physical activity can play a role. In this pre-diagnosis, it's really focused on prevention, and there's strong evidence showing that physical activity is a preventative facet of one's lifestyle to help prevent from a variety of cancers, including breast, colorectal, and prostate cancer. And when we get into, and independent of the naming that I've put here, this was just based on some research that suggests that there's different phases of survivorship, but regardless of this, in the early phase after being diagnosed with cancer, physical activity really plays a role in physical functioning. So we want people to be able to get to their treatments, to be able to sustain some sort of quality of life during the time of treatment, and the quality of life really factors around physical functioning, being able to maintain strength, maintain agility, and ability to move around and get to their treatments. Following that, during this sort of what I would call the end of treatment phase, early end of treatment phase for individuals, it's really focused on quality of life, and physical activity can help individuals increase physical health and increase mental health, as well as social well-being. A lot of activities focus on group atmosphere, group activities. Dragon boating is a good example of that. And there's some literature to suggest that physical activity helps improve spirituality. If you can think of things like yoga in particular are highly driven towards that nature of quality of life. This idea of permanent survivorship, again, whatever we call it, it's sort of the longer-term survivorship period, 1 year post-treatment and beyond, and really the focus of physical activity at this time point is to help reduce comorbidities. Individuals who have gone through cancer treatments are at higher risk for cardiovascular disease, osteoporosis, depression, for example, diabetes, hypertension. So all of these comorbidities can be sustained with physical activity, as well as secondary cancers. And then, of course, in that sort of end of life period, we find that physical activity plays a role in coping more generally with that phase. So there's a range of roles that physical activity plays across the cancer continuum, really. So just to focus a bit on the pre-diagnosis, this is again where the area it has. There's quite strong evidence for physical activity, and you can see here on this slide just showing you the different types of cancer and the percentage of studies that show that physical activity reduces cancer risk. So you can see here 76% of the studies for colon cancer shows that there is some sort of risk reduction as well as a dose-response effect. So what I mean there is the more activity that's done, the more the risk is reduced in that context. So you can see along the way the percentage of studies that show that there is a preventive aspect of physical activity, and it's quite strong overall for the majority of cancers. Okay, so then we talk about what are the benefits after being diagnosed with cancer, and basically the benefits are far-reaching. So I have a slide up here, if you can read it, on all the different benefits that have been shown in a variety of different papers. So you can see anything from actually reducing rates of death. So survival rates are improved, immune function, cardiorespiratory fitness, flexibility, muscle strength, all of those things down to body image. So you can see there that really physical activity targets all levels of the body in terms of benefits to this population. And like I just mentioned, risk of recurrence, and improved survival. So one study, this is the HEAL study in the States, showed that 2 to 3 hours of walking per week after diagnosis improved survival. And in a breast cancer population and a colon cancer, pre-diagnosis physical activity was not related with reduced risk of recurrence, but post-diagnosis was. And this really speaks to, there's been quite a few studies now looking at what's the best time to start physical activity. If you've never been active in your life and you're diagnosed with cancer, if you start now, does it matter? Or should you have been active your whole life? And what we find is that starting anytime is better than not starting at all. And much of the evidence shows that lifetime physical activity, while it reduces the risk of having cancer, once cancer has been diagnosed, any level of physical activity after that is highly beneficial. So, you know, here we just show that physical activity, again, in general, like I mentioned in my introduction, that people are not physically active. And when we take, in particular, breast cancer or women, so women are less active than men, regardless of who we're talking about. Older adults are less active than younger adults. So when you think about cancer and breast cancer, women tend to be diagnosed, the average age is between 55 and 60. So you're talking about an older age female population that's in the least active category already. So the estimates are about 5 to 10% less active than healthy or women without cancer. And the evidence shows up to 87% of these women are not active enough. And this is predominantly with self-report measures. So we know, and I think I have a slide on that later, but we know that self-report may be biased. People tend to say that they do more than they actually do. So if we think that self-report estimates 87% of people are inactive, we can imagine what they actually really are. One study using a national-based study or population-based study showed that breast cancer survivors spent 1.1% of their days active, and that equated to about 4 minutes per day. So, and that was with measured physical activity levels. So when we use accelerometers, which I'll talk about in a second. So this slide just shows you the percentage of individuals meeting guidelines, that 150 minutes that I put up earlier, in a range of different cancer types. You can see here the bottom line is that pre-diagnosis levels are, and this is self-report, so pre-diagnosis levels are around that 30%, 20%. During treatment, those rates go down, and they never really come back post-treatment to what they were before, and the before rates were low to begin with. So when I just talked about self-report versus objective measures, you know, we use a variety of measures in terms of physical activity. The self-report measures are very good at measuring the type of activity that people do, because you can write it, or there's a list that asks them what they've done. It's very good at getting at amount, because if you direct people enough, then they can have an estimate of the amount of activity, and they can usually say what level of intensity they're exercising at. The problem with self-report is, of course, the social desirability, like I mentioned, as well as the fact that when you're measuring physical activity on a questionnaire, it's purposeful. So you think back, okay, when did I put my running shoes on and exercise, or when did I go to the gym? And so it's really only those bouts when you actually made an effort to be active. Whereas accelerometer, which a couple of pictures there for you, are measuring activity all throughout the day. So unpurposeful bouts, whatever you're doing, it's being measured. And so you could argue that neither is better or worse than the other. It depends on what you're actually looking at. If you want to know truly how active someone is, how much energy they're expending per day, then an accelerometer works really well. But if we're trying to change behavior, then we probably want to target the behavior that people know that they're doing, which is the self-report. So a lot of the articles now highlight the fact that when you measure physical activity, you need to use accelerometers, but there is a pretty big downside to that, is that you get a lot of noise in that measure. And so in particular, when we're trying to target higher intensity activity, the accelerometers are measuring everything, and so it's kind of being all clumped together. However, there is benefits to that in that it is an objective measure. It's driven by the social desirability. And then just to highlight the other aspect of the field now, so one push is to use accelerometers to better estimate physical activity. The other is sedentary behavior. So up till a few years ago, really sedentary behavior was was operationalized as a lower level physical activity. So if you're not active, you're sedentary. So it's one continuum, and you're either sedentary all the way up to being active. And now the call is to suggest that sedentary behavior is its own behavior. So you can have low to high levels of sedentary behavior, and you can have low to high levels of physical activity. And they're being operationalized now as two separate, distinct behaviors, because if you think about it, someone can actually be quite sedentary throughout a day, but also meet guidelines. So if you're the type of person that goes for a brisk walk or a run at lunch for half an hour a day, all during the week, you would meet physical activity guidelines. But if you sit from the minute you wake up till the minute you go to bed, other than that half an hour, you're actually very sedentary. So high sedentary, highly active. So that's why they're sort of distinguishing between these two behaviors now. And the literature, not in an oncology context, but generally in general populations, have suggested that sedentary behavior has its own risk factors, its own outcomes. And now there's been, Bridget Lynch in Australia has called, and colleagues have called for this, a new cancer survivorship agenda examining sedentary behavior in addition to physical activity. In that one study that she did with population-level individuals, breast cancer, she showed that 9 hours of their day were spent in sedentary pursuits, and if you remember before, about 4 minutes of the day were spent in moderate to vigorous activities. So what we don't know yet around sedentary behavior is, what are the unique predictors and outcomes in an oncology context, as well as what patterns of sedentary behavior are there. So some of the literature shows how many times you get up from your chair and sit down. So breaks in sedentary time have their own outcomes, and then versus how long you're actually sitting. And so the distinctions around that and the type of behavior that we're studying is still sort of up in the air in the research world. So a lot of what we do now or the focus now is on intervention research, and I would say, as I mentioned earlier, the bulk of it has been on physical activity. Now there's starting to be some interventions on sedentary behavior. So can we create, and we're doing some now with, for example, prostate cancer survivors, looking at can we intervene at sedentary behavior levels. So if we can't get people to a gym, can we at least get them to be a little bit less sedentary? So can we remind them with watch wristbands and emails that pop up to say, stand up, it's time, it's been half an hour, can you stand up now? And does that have an impact on health outcomes and quality of life? So all of this to say, in terms of what I'm going to talk about for the big study that we have going on, is really that little is known about sedentary behavior, and also I would argue that we know quite a bit around physical activity from an intervention context, but we know very little naturally. What happens naturally after diagnosis of breast cancer to physical activity levels? Do they tend to go down? Do they go up? Is it this teachable moment that we hear about or not? And if it does go up or down, are there times after diagnosis or after treatment when we should be intervening? And are there times where physical activity levels are excessively low or high, for example? So that's really what we're focused on here. So I'm just going to talk to you today about the natural changes in physical activity and sedentary behavior among women who have completed their treatment for breast cancer. And sometimes I get asked this question around why did we focus on post-treatment? And to me, during treatment is a very different phase of life than post-treatment. The barriers are very different to be able to be physically active when someone is actively in treatment versus post-treatment, when you would expect that it's possible when you start helping them develop physical activity and lowering sedentary behavior routines that it could be sustained long-term, versus during treatment when things come up, things get going, energy levels are different, you have to get to the hospitals for the treatment, et cetera. So that's why we focused on this post-treatment period. And we were also interested in weight status because weight has a lot to do with breast cancer population. 50% of women in this study are overweight. So we wanted to look at how that impacted physical activity and sedentary behavior levels. And also looking at, most people look at BMI, but now another area of research is really focusing on different indicators of body composition. And so waist circumference, for example, for central adiposity, or waist to height ratio, which is also a measure of central adiposity. So we looked at these two different measures of weight status. So our sample is we have 199 women in our study. This study today, I'm showing you 153 participants that went through for what I'm going to talk to you about today. And we have the mean age is around 55. You can see there the mean BMI is 26. So again, 50% of the population is overweight. And the general treatment, general descriptives here mirror a lot of the population-based studies that we have in Canada and in North America in terms of the other types of treatments that they've had. I'll note down at the very bottom, months since treatment is about 3.5 months. We tried to catch the women as soon after treatment as we could, but some of them just said, I'll start in a month sort of thing. So the average time was 3.5 months. So we targeted them at that point, 3 to 4 months post-treatment. They were recruited from physician referral advertisements in clinics around the area. We had them do self-report questionnaires 5 times, so every 3 months. They also wore an accelerometer for a whole week, for 7 days, every 3 months. They gave us mood questionnaires on 3 days during the week that they wore the accelerometer, and they also gave us saliva to look at cortisol, the biological functioning, on 3 days during that week, and they gave us a blood sample to look at immune biomarkers. So all of this was done every 3 months for the year post-treatment, and then we got follow-up funding to look every year for the next 5 years. So we have really intensive data for the first year, and then every year thereafter we have follow-up data on these women. So we use the actigraph accelerometer. I won't get into the details of this, but we basically did what we should have done with the accelerometer data. The one benefit of using accelerometers as well is that you can look at different intensities of physical activity, so not only moderate to vigorous, but you can also look at light, levels, and you can measure sedentary behavior as well. It has an inclinometer function in it, so if you're wearing it, it says whether you're supine or not, basically, is how it looks at that. We had weight status, so we had a trained lab technician measure weight, height, waist circumference on the first data collection, and after that, the women were taught how to do it, and they did their own waist circumference and weight for every measure after that, so they didn't have to come to the lab every time. And the stability estimates are there. They were quite stable in terms of their weight in that year. So this is who are meeting the guidelines, so that 150 minutes of moderate to vigorous activity. You can see here measured activity. We start off with about 29% to our meeting guidelines, and it drops down to 22% at 12 months. So if they're, the title of my slide was sitting on the crest of the teachable moment, and I guess my argument would be if there was such a teachable moment, we either missed it in this data collection or it doesn't exist, because we would expect those numbers to actually go up, not down. So we don't know if that baseline point post-treatment is sort of the highlight and that they did change their behaviors and now it's on the downhill or not. But I would argue again that this is the time frame that will be long-lasting lifestyle behaviors. So a little bit discouraging in that regard. Here is just looking again at same sort of data, but this is the percentage of time that they spent in moderate to vigorous activity. So you can see 2% of their time at time 1, it goes up, 1.95, it goes up to 2, and then it drops thereafter. And there was a significant linear effect for this variable. So moderate to vigorous activity, percentage of time spent in it, basically decreases over time. The opposite for sedentary behavior, so you can see here, time 1, about 78% of their time is spent, and then it drops down before it goes up. Now, obviously, the axis, the time period here is quite small, so you can see it ranges from 77.4 up to 78.8. So we're not talking about a huge increase, but it is a significant increase because this is percentage of time. It equates to about 10 minutes difference in terms of their sedentary behavior. So I just wanted to also highlight that one of my interests is really in looking at focusing on light activity, because I feel that, or we know that most individuals don't like moderate to vigorous physical activity. If you ask people what they enjoy and the activities that they enjoy doing, it tends to be walking predominantly, and then you know, things like swimming or yoga, Pilates, those kind of activities, gardening, housework. I don't know who likes housework, but so those types of activities are really the light activities, not moderate to vigorous. And what I feel that we've done a disservice in the literature is we tend to always reduce or not look at the light activity, and we always highlight the moderate to vigorous. But we need to better understand that the effects of light activity to know whether helping people just engage in light, is that okay? Can we gain benefits from that? And so that's part of this study that we're also looking at, is trying to identify what we can do, what light activity is associated with, so that we might be able to target that level of activity a little bit differently than we have in the past. So these are just looking at the associations between those different intensities of activity in this study. This is just baseline data, so you can see really the displacement between sedentary and the light and lifestyle. So they're highly correlated. If they're sedentary, then they're not. Then they're reducing their time spent in light and lifestyle activity more so than moderate to vigorous intensity. And that's basically the bottom line of that slide. And then if you remember, the objective was to also look at weight status. So you see here, the blue line are those individuals who are considered overweight based on waist to height ratio, and the gray line are those women who are of healthy weight based on that. And you can see here the general trend for those people who are overweight just goes up. And again, if you were going to target an intervention or you were to look at this data, then at baseline, you really could start with the individuals who are overweight. Healthy weight women, in this study, it tends to be about 6 months before before it goes up again. So, you know, again, maybe that's a time frame to start looking at intervening with these women. And if you think back to the graphs that I had, the other group-based graphs show that about that 6-month time frame is where sedentary behavior starts to increase and physical activity levels really are decreasing. So if I was to work with physicians at that point, it would be around that time frame where I would argue we need to start looking at physical activity. We need to start addressing physical activity in clinics to suggest that that's when the information needs to get out there. This is percent time in MBPA, so for both groups, they sort of go down. The healthy weight women go up a little bit before it starts dropping and are always more active than the overweight women. And this was just showing you the light and lifestyle activity, just to show you that the trends are very similar in that. So around weight status, the healthy weight women are always more active and less sedentary than the overweight women in this sample. So, so then I just wanted to quickly talk a little bit about so what? We know now natural changes in physical activity, they tend to go down. Sedentary behavior tends to go up. That 6-month mark tends to be the time that we want to target. But does this all matter? And so really in this study, we're focused on a number of facets of mental and physical health, and I just wanted to share with you a couple of the findings that we have so far in this regard. So this was the health model that we're following for this study. So generally speaking, physical activity and reductions in sedentary behavior should relate to better mental health. Better mental health would improve biological functioning that we're operationalizing as cortisol, like stress levels, and immune function. And with healthy levels biological functioning, we would expect better physical health. So that's how we're looking at. And so today I'm just going to look at, generally speaking, some of the associations between all of these facets. And looking at all of these things, I'm just going to present to you now baseline to time 5. So change over 1 year, is that in physical activity and sedentary behavior? What does that relate to in terms of these other facets? So you can see here, these are correlations between change in physical activity on the left and change in sedentary behavior over that first year, and a range of different variables that I looked at for the presentation today. So the ones in bold are significant at p value of 0.05, and those in italics, if you can see them, are are significant at P is 0.10. So what I'll highlight is that physical activity, the first observation that you get right away is that physical activity is stronger in relationship to all of these facets than sedentary behavior. However, we do see some interesting associations with sedentary behavior. In particular, if sedentary behavior goes up, stress goes down. Same thing with physical activity, so the same type of association. And I would argue that sedentary behavior in an oncology context is going to be complicated to look at because these women say that they need that time. They need to just sit down. It's actually part of their coping repertoire. It's actually beneficial to their mental health to be sedentary in some capacity. So arguing that perhaps that is part of the argument in that context. You can see, though, that higher increases in sedentary behavior are associated with increases in cancer worry, and increases in sedentary behavior are related to increases in sleep quantity. So the more sedentary they are, the more they sleep. And the opposite sort of trends we see with physical activity here over time. PTG is post-traumatic growth, so that was one facet that we wanted to look at from a positive aspect. I know there's a lot of controversy in the literature as to whether post-traumatic growth should be studied or what it actually is, but we did assess it over those 5 time points. So, and it is related to physical activity. So the more active the women are, the more they experience aspects of growth. And we saw that as well in some of the dragon boating stuff that we've done as well. And just one more point here, one of the interesting stuff in our data, and this is with only 78 women who gave us full blood samples for all 5 time points, but C-reactive protein is lower in those women who engage in physical activity, and that trend that we see actually is consistent across all 5 time points and at within level and between levels. So suggesting that generally speaking, we see this type of association between physical activity and decreases in immune in CRP, but we also see it that if a woman is more active than her average, that she has reductions in CRP. So being a little bit more active than you usually are actually is protective of immune function as well as generally being physically active. So that's an interesting finding that we're grappling with and writing up right now. So just to summarize that, changes in light and lifestyle physical activity, which I didn't put on the previous slide, were related to decreases in cancer worry and stress. Changes in moderate to vigorous physical activity were related to a bunch of mental health and physical health outcomes, and changes in sedentary behavior were related to a little bit less than physical activity overall. And when we tease apart some of those associations, we also see that link between moderate to vigorous physical activity and these outcomes is really driven by moderate intensity physical activity. Very few women actually attain a vigorous level of physical activity. I think it's 0.01% of their day is spent in vigorous. So when we even say moderate to vigorous, it's really moderate intensity activity. So we do need to target interventions targeting that moderate to vigorous physical activity, but also based on some of the stuff that we're seeing, light and lifestyle activity does have positive benefits as well. And I would also argue that light and lifestyle physical activity are, and I put precursor up here because if we can help people start to be active at that light level, it may in fact translate into moderate to vigorous at some point. So there may be a continuum at which we need to target light activity first. There are some benefits, and then push them to be more actively engaged as time goes on. And there's a number, that's really following any of the typical behavioral counseling, psychology, physical activity literature. And I already talked about the nature of sedentary behavior in this oncology context. So this graph is just showing you, again, where we need to go with a lot of this literature is the data that I just presented was at a group level. So taking all 153 women that we had full sample in the study and looking at mean levels. But it doesn't mean that there aren't women who are increasing, and it doesn't mean that there's women who aren't decreasing a lot. So what we need to do is and what we're doing now is teasing out that in a data analysis form where we can look at individual level physical activity levels. And you can see here, I think I took 13 participants, and I just graphed all 5 time points for you to see the differences over time in those 5. So you could see, you know, the teal color one there really goes up at time 2 and comes way down. You can see some of the blue ones are up quite high and come down. So, and then the people at the bottom who sort of stay stable. So what we want to do is identify those women who are decreasing, the women who are increasing, and the women who stay the same, and looking at predictors and outcomes of those women to see what we need to do. Because it really is in physical activity interventions, it's not a one-size-fits-all kind of approach that we need to take. And, you know, if resources weren't limited, we would take that perspective. But we need to do the best we can with what we have. And so I just talked to you again about that time period at 6 months where we should probably be intervening. This graph is just what I also showed you in terms of the data. So that time in red is really where we probably should be working with the oncologist and the follow-up appointments with practitioners, whoever that team may be, to target physical activity at that time frame. I'm not going to talk about the other side there. And this slide is just the American Institute of Cancer Research putting it out for cancer prevention, showing you a typical active day versus a sedentary day. So you can see the top person kind of gets up, walks everywhere, gets up to get water, you know, goes out for a walk at lunch, walks, takes his bike home, and is quite active and has, you know, quite a low risk for cancer. Whereas the bottom person there, and you can see there, is basically gets up, sits down, gets in her car, sitting at desk, sitting, gets in her car to go home, sitting, watching TV at night. So you can see her risk is the highest. So, you know, we often target, and with the research that we're doing now showing that light activity is beneficial, reducing sedentary behavior is beneficial. Some of this stuff is important. You know, it's really about those reminders to stand up more throughout the day and try to help people identify times in their day when they can be more active. And just to end, this is our new study. Actually, Jennifer Jones is a co-investigator on this with me. And basically, this study was developed to help more women become active. And so one of the barriers that we often hear to physical activity levels is that women don't have someone else to exercise with. So, or to call them up, or the information needed to be active. And because there's not enough trainers in the world to be matched one-on-one with every single person, we've developed this online, what we call active match. So I describe it as my Lava Life for exercise. Really, it's helping women find a match to their activity levels and someone else who they can exercise with, or someone else that will just call them on the phone and say, hey, were you physically active today? So depending on what their needs are, they'll develop a profile. The profiles will be matched to their top choices, and they'll be able to identify that person and go out and exercise with them, or again, have them call them on the phone and see how they're doing. So we will, part of this website will be providing them with information on how to set goals together, how to keep people accountable together, as well as examples of exercises that they can do in pairs or in small groups, because some of the women say they want to be in groups of 3 versus just 2. So we're trying to help people in any way they can, and part of this process might be, the value of it might be after, you know, there's a lot of programs in hospitals for people once they're diagnosed with cancer that last 12 weeks, provide physical activity as well as a bunch of training, and then they're left on their own. So if we can offer this kind of service for the post-program time, then maybe we can help more people be active. Right now we're focusing on women, but eventually I've had a lot of emails and calls about this from men and from women who don't have cancer. So you can't appease everybody, but this is a good first start. So I just thought I'd put that up there. So I think that's it. Just to acknowledge our funding for the data so far.